Have you ever tried to describe a pain that no one else can see? No cut, no bruise, nothing on the outside, but on the inside, the suffering is just immense. Well, today we're going to dive into exactly that. We're talking about neuropathic pain, an invisible injury that comes from the very system that's supposed to be protecting us.
Listen to these words: burning, stabbing, electrifying. These aren't just descriptions. This is the reality for people trying to explain what's happening to them. You can tell right away, this isn't your typical ache or sore muscle. This is something else entirely.
And this isn't some rare, obscure condition, not at all. Studies show that up to 1 in 10 people, 10% of the population, experiences pain with these exact characteristics. Just think about that for a second. That is a staggering number of people living with something that's so hard to see and even harder to explain. So what on earth is going on?
All right, let's get into it. To really get neuropathic pain, you have to kind of flip your understanding of pain on its head. This isn't your body sending a helpful signal that something is wrong, like a cut on your finger. Here, the signal is the problem, the pain is the damage, and it's located inside the nervous system itself.
So here's the official definition. It's pain from an injury to the somatosensory system. Just think of that system as your body's internal wiring. It handles touch, temperature, all of that. In neuropathic pain, those wires get crossed, or it's like a faulty car alarm that just keeps blaring for no reason. The alarm system itself is broken, and it's sending these horrible false pain signals straight to your brain.
So what causes these crossed wires? Well, the list is long and really varied. It could be something physical, like a pinched nerve in your back. For a lot of people, it's nerve damage that comes from years of having diabetes. But it can also be the lingering, awful pain after a bout of shingles, or the result of a stroke or a spinal cord injury. And then there are specific conditions like trigeminal neuralgia, which causes this absolutely excruciating facial pain.
You can see why diagnosing this is basically detective work. A doctor has to look at all these complex, strange symptoms and try to crack the code to find out where the system is malfunctioning.
And what's really wild is that doctors are looking for two totally opposite things. You've got what they call plus symptoms, where everything is hypersensitive. A little pinprick might feel like a serious wound. Or, get this, even the gentle touch of a bedsheet can become agonizing. But then they also look for minus symptoms, things like numbness or a reduced sense of touch. And the really confusing part, a person can have both of these, plus and minus, in the exact same spot.
So this leads to a really logical diagnostic path. First, it's considered possible just based on the patient's story, when they use those words like burning or stabbing. Then it becomes probable if a doctor can actually find those sensory changes during an exam. And finally, it gets confirmed when a test, like an MRI, gives them a clear picture, actual visual proof of the lesion or damage.
And check this out. This is a perfect example of that final step. This scan is from a 62-year-old woman who had this terrible stabbing pain in her thumb and index finger. On the left, you can see something is there, a lesion. But then on the right, after they inject a contrast dye, boom, it lights up. It's a nerve tumor. Suddenly, the invisible became visible. And the best part? Surgeons went in, removed it, and she became completely pain-free. An amazing outcome.
And here's another look. This image shows the kind of extensive nerve damage you see in someone with long-term type 2 diabetes, one of those common causes we just talked about. You can literally see the nerve bundles, the fascicles, showing all the signs of distress. This is the physical proof of what's causing that constant burning and tingling.
Okay, so once the detective work is done and the cause is found, what's next? What can actually be done? Let's talk about the path to relief, because there's a whole toolbox of treatments out there.
Now, the first line of defense is usually medication, but what's so interesting is the kind of medication. You'll see antidepressants and anticonvulsants used all the time, and it's not because the pain is in your head or anything like that. It's because these drugs are designed to work on the brain's chemical signals and the nerve's electrical signals. They basically help calm down all that faulty wiring and just turn the volume down on those false pain alarms.
But what if you could do more than just turn down the volume? What if you could actually go in and fix the faulty wiring itself? Well, for some people, especially when meds aren't cutting it, surgery can do just that. It's a chance to target the root cause of the problem directly.
One of the big surgical strategies is called decompression. And the idea here is really simple. If a nerve is being physically squeezed, say by a tumor or even a blood vessel, the surgery just aims to create space and relieve that pressure. It's almost like unkinking a garden hose to let the water flow smoothly again.
So does this unkinking strategy actually work? I mean, how effective is it in the real world? Let's take that condition we mentioned before,
Trigeminal neuralgia, the one that causes those terrible electric shock-like pains in the face. A lot of the time, the cause is exactly this, a blood vessel pressing on a nerve.
Well, the results are pretty incredible. One major analysis found that a specific decompression surgery gave patients long-term, complete pain relief in almost 93% of cases. 93%! You fix the mechanical problem, and for these people, the pain just disappears. Then there's another approach called ablation. Now this one is a bit more direct. It involves intentionally destroying the specific nerve structures that are sending out the rogue pain signals. It sounds like a paradox, right? Damaging the nervous system to stop pain, but for really severe cases, like intense pain from a tumor, it can be a lifesaver.
And that brings us to what might be the most exciting frontier, neuromodulation. Instead of cutting or destroying anything, this uses tiny, precise electrical currents to change or modulate the pain signals. The best analogy? It's like a pacemaker, but for your nervous system. And the huge advantage is that it's often minimally invasive and totally reversible. And the level of precision here is just amazing. Doctors can put a tiny stimulator right on the spinal cord, that's SCS, to intercept pain signals on their way to the brain. Or they can target something called the dorsal root ganglion, or DRGS, which is like a busy intersection for sensory nerves. They can even target tiny peripheral nerves, PNS, in an arm or a leg. There's even a non-invasive version called RTMS that uses magnets outside the skull to change brain activity. It's all about finding the exact right spot to apply the therapy.
So you've got this huge tool gauze, right? Medications, different surgeries, these super advanced technologies. What's the big takeaway from all this research? What's the bottom line?
The single most important takeaway is this. There is no silver bullet. There's no one-size-fits-all fix. The treatment has to be totally personalized. Sometimes you're cause-directed. You're going after the source, like removing that tumor we saw. But other times, if you can't fix the source, you have to be symptom-directed and just focus on managing those pain signals as best as you possibly can.
And that's exactly why this has to be a team sport. The best results always happen when you have a whole team, radiologists, surgeons, pain specialists, neurologists, all putting their heads together. They can figure out not just which tool in the toolbox to use, but exactly when and how to use it for that one specific patient.
And that really brings us to the ultimate question we're facing. We have this incredible, ever-expanding toolbox to treat this invisible injury. So the real challenge going forward isn't just about inventing new tools. It's about perfecting the art of being master locksmiths, of figuring out how to match the exact right key to the exact right lock for every single person who is living with this pain.